Good morning, everybody. It's morning for me, probably it's evening for some of you, or the middle of the day for some of you, because people from all over the world have joined these webinars, and I presume many of you are here today. I will be very brief. You already know Dr. Sonya Norman, Professor of Psychiatry at the University of California, San Diego, and one of the world-class experts in addressing multiple issues related to combat trauma, war-related trauma, and trauma in general. And I'm very, very pleased that she found time and to share her experience with our colleagues in Ukraine and other countries. So today is the sixth webinar from the first series, because there will be more. I just want to remind you that following the webinars, we are planning a series of clinical consultations, online clinical consultations. And the reason for that is you just gain a little bit of knowledge, a little bit of skills. The important thing is put them to work as quickly as you can. And definitely this may not be easy for all of you to start using those skills correctly and properly. And you may feel frustration, you may feel some disappointments, you may feel some doubts, exactly to make your life easier and to make, at the end of the day, the patient's life easier. We will provide you a series of clinical consultation. The reason for that is the way it will look like. If you had difficulty with a patient or any other clinical situation, that will be your chance to share it, and then we will be able to dissect it and help you with the skill implementation. So just so you know, there will be a series of clinical consultations, what we call implementation support. But today, let's focus on the sixth webinar. At the end of the webinar, the last 10 minutes will be for questions and answers. You can type your questions in the question section of this software. And I wish you success. Take good care of yourself, take good care of each other. And thank you, Dr. Norman, for spending time with us and sharing your huge experience. Please, the floor is yours.
Thank you. I'm so pleased to be here again today and to be able to share this information. Can you confirm that you see the slides the right way? Oops, let's see. Okay. So today we're going to cover. Oh,
sorry, not currently. If you could just hit the play button in the control panel, we should then be able to view it.
Okay, that's in the wrong view though. Let me change.
Yes.
You just need to put them full screen, and then we should.
Let me. For some reason, I have to stop sharing to do that, and then it was in full screen. I always struggle with this one. So let me put it in full screen here, and then there we go. That's good, right?
Yeah, that's great.
Okay, terrific. Thank you. Thanks for your patience, everyone. Okay, so we're going to talk about traumatic stress and post-traumatic stress this morning. This is kind of completing the arc in that over the last 6 seminars, we've talked about how to help people during a traumatic event, right after they've been removed from the dangerous situation, and for example, are displaced or elsewhere where they're safe but still very disrupted, impacted. And today we're going to talk about downstream. The trauma is over, they're safe, but they're not doing okay. They're having symptoms, they meet criteria for post-traumatic stress disorder, which we'll call PTSD, and what to do when people with that come to you and how to help them. So we'll talk about how to identify PTSD and what the best practice treatments are, including psychotherapy and medication. And we'll talk about other resources you can use to help as well. So PTSD is different than most psychiatric conditions because it requires a traumatic event to occur. So depression can come on out of the blue. Anxiety disorders can come on out of the blue. but someone can have all the genetic priming for PTSD, and if they don't experience a traumatic event, they won't get it. So when I say traumatic event, I mean really a life-threatening event. So I'm not talking about stressors like your car breaking down or you have more bills than you're able to pay. I'm not even talking about major life events like losing a job or a divorce or getting married, which can be positive and also very stressful. I'm really talking about traumas where someone thinks they might die or they witness other people dying. So relevant to Ukraine right now, of course, is war zone exposure, combat, being somewhere where war fighting is going on around you, seeing injuries, seeing people die, thinking you might die. Physical and sexual assault are a type of traumatic event. And we have heard of reports from Ukraine of people being sexually assaulted, very serious accidents, so being in an explosion, natural disasters like fires or hurricanes, and child sexual or physical abuse. Even when we're not in times of war, we know from large epidemiology studies that most of us will experience a traumatic event in our lifetime. This is US data, so something like 60% of men, 50% of women. Even in peacetime in some countries it might be higher or lower, but this is one example. And the typical course after a traumatic event is that most people actually recover on their own and are fine. Most people don't go on to develop PTSD or other problems. So right after a traumatic event, let's say someone's city is bombed, they see, the injured, the dead, they're very impacted by that. They may look like they have PTSD. They may startle easily, they can't sleep, they can't concentrate, they can't get what they saw out of their minds. But over the next month to 3 months, those symptoms gradually recede. And by the end of 1 to 3 months, they're very, of course, impacted by that experience, but they don't have PTSD. They're kind of functioning as they did before in their job and their relationships. They feel okay. But then a small number of people kind of stay in that elevated state, stay in that hyper-aroused state where they continue to have those symptoms. And those are the people who may have PTSD. So we know that about 6% of the general population, again, this is US data, it can vary country by country, but can go on to develop PTSD. But this is pretty typical that in a lifetime, most people who have trauma don't develop PTSD, and depending on the type of traumatic event, about 6 to 20% do. So that traumatic event, again, it can mean that the trauma happened to you. It can mean that you witnessed someone else experiencing the traumatic event where you thought they were going to die or they did. It could be learning about the violent or unexpected death of a friend or a family member. So this really means violent and unexpected. If someone has, a long course of cancer and the prognosis is that eventually they will die, that wouldn't count for PTSD because it's not unexpected. Or if, someone passes away from old age, it's not violent, it's not really unexpected. So to be a traumatic event for the PTSD diagnosis, it has to be violent and unexpected. And then another situation is experiencing repeated or extreme exposure to aversive details of traumatic events. So these are people who aren't necessarily in danger themselves, but they're seeing over and over again kind of horrific situations. So this might be people whose job it is to clean up bodies after explosions, after combat, and bury those bodies. So they're seeing these bodies that have sustained these horrific injuries. So that would be an example of they're safe. They don't think they're going to die, but over and over they're exposed to these very extreme aversive kind of visions and work. So once we've identified that someone has a traumatic event, we want to find out if they have the symptoms of PTSD, because again, a lot of people have trauma but don't have PTSD. So the way I'm thinking about this is someone might come to your office, they're telling you, some things that make you think that they experienced trauma and that they haven't yet recovered from it, and you want to assess if they have PTSD. So once you've established that they have trauma, with the symptoms that you're looking for is at least one intrusion symptoms. And intrusion symptoms are where they can't stop thinking about the traumatic event. So either that's during the day, it pops into their mind a lot, even when they're not trying or trying not to think about it, or maybe it's in their nightmares, they're having nightmares about it, or maybe they are actually feeling like they're back in that situation. We call that a flashback, when they actually think for a moment or for some extended period of time that they're back in the traumatic event, even though some time has passed and they're safe. At least 2 negative alterations in cognitions or mood. I'll show you more what those are in a minute. At least 1 avoidance symptom, and at least 2 arousal and reactivity symptoms. So let me show you more of what all those are. So the intrusions, again, are the recurrent distressing dreams or memories or feeling like it's happening again. The avoidance symptoms is trying very hard not to think about what happened, the trauma, trying to avoid anything that reminds you of the trauma, and trying to avoid people, places, or activities that remind you of the event. So, so it might be what we hear from people with PTSD is they avoid, maybe people who were there with them because they don't want to talk about it. They don't want to think about it. Or maybe during their trauma, it was very loud, very crowded, very chaotic. People were running around trying to figure out where they can be safe. And so now they avoid anywhere that might remind them of that. So maybe they avoid crowded parts of the city or crowded stores, or going to football games, which they used to enjoy, but now the crowds and the noise, it creates a great deal of anxiety for them. And these avoidance symptoms are very critical to PTSD. You can't have PTSD if you can't have avoidance. And they're also very limiting. So if you think about someone's life, it kind of shrinks smaller and smaller and smaller, where we know some people with PTSD who don't even want to leave their house, because at first they started avoiding the store when it was the most crowded. And then they started avoiding it at all because it might be crowded. And then they started avoiding even the smaller store that doesn't get crowded just in case. So avoidance is kind of like a snowball that gets bigger and bigger as it rolls, and someone's life shrinks and becomes smaller and smaller. So it's one of the things we definitely want to treat when we treat PTSD. The negative alterations in cognitions and mood, there's several ways that this can be expressed. Some people can't remember part of the trauma. Some people, it looks kind of like depression. They lose interest in things they used to enjoy. They feel detached from others. They tell us they can't experience positive emotions. So for example, I remember a young man who'd been through war telling me, I know I love my baby, but I don't feel the love. I can't feel positive emotions. They have a lot of negative emotions like anger, shame, guilt. They have extreme blame for themselves or others, more than the situation calls for. They're very, that blame or that is a very big part of their life. And they might have very exaggerated negative beliefs or expectations after trauma. Some of the ones we hear the most are, now I realize nowhere is safe, or now I realize I'm incompetent to keep my family safe. I'm no good, or the world is no good. People can't be trusted. So these very grandiose statements that really then affect how they interact with people, how they interact with the world. And so those also, when we identify those beliefs, we want to address them in treatment because they cause a lot of impairment in someone's life. And then arousal and reactivity symptoms are part of PTSD. So this might be irritability and anger. It might be in some people reckless or self-destructive behavior. Some of the veterans I've worked with tell me, I'll get on my motorcycle, no helmet. I'll go as fast as I can on the highway. I don't really care if I live or die. So that could be an example of that kind of reckless or self-destructive behavior. It could also be drug use. It could take a lot of different forms. It could be putting yourself in bad relationships where you know you're going to get hurt. Other arousal and reactivity symptoms are problems concentrating. Hypervigilance, this is where someone with PTSD is always scanning the environment, making sure things are safe. They'll only sit in a room where they could see all the windows, all the doors, because they're always scanning. They never feel safe. That's hypervigilance. Exaggerated startle, where maybe there's an unexpected noise and they jump and then they have a very hard time settling physiologically. And poor sleep, poor concentration. So you could see how someone who's living with these symptoms, it's very hard to get rest, get good sleep, engage in your work, engage in your relationships, because you're startling, you're scanning the environment, you're having trouble concentrating, you're tired from poor sleep. These are very impairing symptoms as well. So again, the treatment piece becomes very important. PTSD is not the only thing that happens after trauma. So a lot of times I've noticed, when I've led PTSD treatment programs, people will send me someone because they're a veteran and they've experienced trauma, or they've experienced another kind of trauma, and they'll assume that the person needs PTSD treatment. But in fact, having depression, having anxiety, having more than one is just as common, if not more common, than having PTSD. So assessing the actual symptoms and making sure you know what the person is presenting with is very important, because the way we treat depression is actually different than the way we treat PTSD. And you want to give the person the treatment that will work for them. So one of the questions I often get is, why do some people get PTSD while others don't? In fact, most don't get it. What are some of the things that contribute to that? Well, we don't have a definitive answer. I certainly can't meet someone and tell you if they will or won't get PTSD after trauma, but a good deal of research is working to try to understand this. So I'll share some of what we do know. So some things are about the person. So for example, if they already have a long history of trauma, of adversity, a difficult life, if they already have other psychiatric disorders like depression, anxiety, schizophrenia, whatever it might be, bipolar, if they then have a trauma, they're more likely to develop PTSD. Certain demographic characteristics put someone at higher risk. So for example, female gender, being younger, being a minority, either racially or ethnically, having less education. These are small risks. These are from large epidemiologic studies. So if they take, thousands of people, being female puts you at, 0.00 something higher rate of getting PTSD than being male. So, again, it doesn't tell me about anyone who comes into my office, whether they do or don't have PTSD, but across an entire population, these factors could put someone at slightly higher risk. And we do know that there are genes that predispose someone to getting a psychiatric diagnosis, but we don't have a PTSD specific gene, the same genes we could look at as risk factors for other mental health conditions as well. And then there's some characteristics of the traumatic event that also put people at higher risk for developing PTSD. So if the event was deliberate and caused by another person, someone is more likely to develop PTSD than if they went through a disaster, a fire, an accident. There's something about another person assaulting us or a combat situation. There's something, I think, that it's harder for our brains to make sense of how could another person cause this kind of pain for me, that puts someone at higher risk than if it's an earthquake. And then what happens after the trauma? Does someone have people who love them and support them around them? Can someone manage their stress? When those things aren't in place, when they don't feel supported, when they continue to experience trauma or a great deal of stress, they're more likely to develop PTSD. Another thing I want you to know about PTSD is that it very rarely occurs by itself. It often happens with other diagnoses as well. So some of the most common ones are depression. We see a lot of drug use, alcohol use, substance use, abuse of prescription medications. Maybe it starts with people trying to manage their symptoms, trying to, sleep better, or take something so they can handle that social situation that they want to avoid. But of course, it can become a standalone addiction very quickly. And also traumatic brain injury we see a lot, especially after war, where people might be in explosions, they might get thrown, or after intimate partner violence, where, in the course of the violence, someone might get choked or otherwise not get enough oxygen to their brain for some time during an injury. So we often look for traumatic brain injuries as well. Only about 20% of people who have PTSD have no other mental health diagnosis. And then the kinds of things we often see with PTSD is higher unemployment rates, more medical illness, difficulties at home or work, relationship difficulties, more suicide attempts than people who don't have PTSD, and overall lower quality of life. And again, that comes back to those symptoms I described to you: when you're avoiding, when you have hyperarousal, when you're not sleeping, when you have difficulty concentrating, when your body's constantly on and stressed, you have more medical illness, you have more difficulty functioning. So these things aren't surprising. We have several major international guidelines for treating post-traumatic stress disorder, PTSD. International ones include the International Society of Traumatic Stress, NICE out of England, Phoenix out of Australia. In the US, we also have the Veterans Affairs and Department of Defense joined together to create a PTSD treatment guideline every few years, updated, and the American Psychological and Psychiatric Associations. All of these review the literature of research of clinical trials and other relevant studies to see what treatments are effective. They look at the quality of the research, so they don't want to base the recommendations on very poor studies that, used a design where you really can't conclude anything. So they use high quality studies, or as high as they can, and they look at psychotherapy, they look at medication, they look at technology-based treatments, they look at other kinds of treatments of interest. Like right now, in the US at least, there's a lot of interest in psychedelics. We don't know yet if that works or not. The research isn't done, but the research is reviewed every few years. And because there's so much interest in treating PTSD, all of these get updated fairly regularly because there's always new trials, new information. So I'm going to talk with you now about treatment, and I'm really going to base what I share with you on what we know works from research and what's highly recommended in these treatment guidelines. And we actually wrote a paper a couple of years ago where we compared across all these 5 major guidelines, and the recommendations were very, very similar across them. So I'm going to share what all of these international and other guidelines agree on. So one of the strongest findings across all of these guidelines is that trauma-focused psychotherapy is the best. And I'll talk with you quite a bit about what trauma-focused psychotherapy is, but that it's a very effective treatment for PTSD, that with trauma-focused, more than 50% will lose their PTSD diagnosis. And even those who don't lose their PTSD diagnosis, many more will have symptom reduction that really improves their quality of life. So they might still have PTSD, but instead of their symptoms being here, they're here, and they're much more able to do the things they want to do, live the life they want to live, not be as impaired by their symptoms as they were before treatment. Medication is also very effective, and a little less than half lose their PTSD diagnosis, and these are specific medications. We'll go over these as well. And if someone gets no treatment, only about 12% lose their diagnosis. So once people have PTSD for more than 3 months, it really isn't that likely to go away without treatment. So treatment is very important. So let's talk about trauma-focused psychotherapy first, and let me explain what I mean by it. It's a therapy that uses different kinds of techniques. They could be cognitive, where we look at how someone's thinking about their trauma and the world. It could be emotional, it could be behavioral techniques, where we have them go out and stop doing things they've been avoiding because of the trauma. But we use these techniques to help them process that traumatic event. And processing that traumatic event is central to the therapy. It's not something we do in just one session, but we do it across the entire therapy. So, some therapies are different. They'll say, let's look at what's happening to you now. you're not, you're not taking good care of yourself. How about this week you read a book, you light some candles, you do some things to relax. That's focusing on the present. That's saying, what symptoms do you have now? Let's focus on those. This trauma-focused psychotherapy is different. We actually have people talk about the traumatic event, think about it. If there's painful emotions that they haven't processed because they've been avoiding it, we actually have them feel those feelings. Some people have compared it to an infected wound. If you have an infected wound, you can't just put some stuff on top. You really have to clean out the wound for it to heal. So this is thinking of trauma a little bit as that kind of infection where we want to process it. We want to clean it out with the goal of really genuine, deep healing. So what are some of the trauma-focused psychotherapies that have the most evidence? There's prolonged exposure therapy, cognitive processing therapy, eye movement desensitization and reprocessing, and written exposure therapy. I'm going to go a little bit into each of these so that by the end of this talk, you at least have some idea of what each of these are. And I'll share some resources at the end that can make it possible to learn more about these. The first three, prolonged exposure, cognitive processing, and I'll call it EMDR because it's a lot to read, eye movement desensitization and reprocessing each time. Those three have been around the longest. They've been studied since probably the 1990s. They've been studied in over 20 trials each with different populations around the world, with people who have many different traumas, not just one, with people who have comorbidities like substance use and traumatic brain injuries and other things. And across these studies, these therapies work well. And written exposure therapy is newer. We've only seen papers coming out of it about it in the last 5 years or so. But the studies are showing over and over that it's as good as these other therapies. And what's nice about it is it's shorter. So these other therapies take about 12 meetings or sometimes more with a therapist, and written exposure is about half of that. So let me go ahead and talk about each of these a little bit. Prolonged exposure therapy, it helps people process the trauma by talking about the trauma and doing which they've been avoiding, and doing the things that they've been avoiding. So the idea with prolonged exposure is that most people after trauma don't get PTSD. The ones that do tend to be the ones who cope through avoidance, and they've never given themselves that chance to really feel all the feelings that came up that day, the fear, the horror, the grief, whatever it might be, the guilt, the shame, the sadness. There's so many different emotions that can come up during trauma, and that they've made their world very small through the avoidance. So in PE, we literally have people make a list of the things they've been avoiding and how distressing it is from 0 to 10 to do these things. So maybe for someone it's a 3 to, I'll give you an example for people who've been in explosions where they smelled gas, maybe a truck exploded or a building was blown up. So let's say they're avoiding the smell of gas because that's very distressing for them. So maybe they say just driving by a gas station is a 3 and stopping and putting gas in the car is a 10. And so we have them make all these different lists and rate the things and how distressing it is to think about doing them. And so we have things like, pumping gas, going to busy stores. We also try to do things that are very meaningful to them, like hug my grandchild, get on an airplane so I could see family I haven't seen in years. Like, we want to do things that will really bring joy to their life, bring meaning to their life. We want those things on the list too. And because often people aren't doing things they used to enjoy, we put some of those things on the list too. Like, I used to love to go fishing and I just don't care anymore. Well, let's put that on the list. And we start assigning things. We start assigning things that they've rated about a 5, not too low, not too high, just so they could see that, yes, their PTSD is telling them those things are dangerous. But in fact, when they go do them, oh, it's, filling up gas right now in the city is not dangerous. It was dangerous, during the war, and now it's okay. So, or it was dangerous when I was in that city, but now I'm somewhere else. So we want their brain to have that experience. We want them to have that experience. And what happens is what they originally said was an 8 becomes a 2 or a 0, and they realize it's okay to do. And same, we have them in session tell us the story of the trauma over and over and over. And at first that's so hard for them. But over time they realize, oh, it's just a memory. Yes, I was in danger when I was there, but now it's a terrible memory, but it's not that dangerous to think about it because I'm safe now. And so we have them tell the story until they realize that. The other thing that happens is they remember details, they remember more. So for example, I have a lot of people who say, you know, what happened was all my fault. And then after they go through the story many times, they say, oh wait, I couldn't have changed the outcome. There's nothing in my power that I could have done that would have made things turn out differently that day. And a huge weight lifts off them. So it's very powerful to have them retell the story. So that's PE. You know, where we teach them about this model, we help them with some breathing skills to relax a little, and then we do the in vivo exposure where they go out and do the things they've been avoiding, and we do the imaginal exposure where they talk about the memory of the trauma. So let's turn to cognitive processing therapy. Cognitive processing therapy focuses more on thoughts, whereas PE was more about doing. This is more about thinking. And so we help people identify these very common thoughts that get disrupted during the traumatic event. So a lot of people will come out of trauma who develop PTSD with these very extreme thoughts, like the world is never safe. No one can be trusted. What happened was all my fault. I can't be trusted because look at how I messed up. And so we help them start to identify these thoughts, and then we help them start to challenge these very extreme, unhelpful thoughts to come back to a reasonable place of, yes, in that situation, there was extreme danger. There were people who couldn't be trusted. But when I look at other times in my life, this person would never have let me down. They could be trusted. You know, we help them come back to a more balanced place through a series of exercises. And so here too, we do some education at first about the traumatic event and PTSD and why it develops and how we're going to treat it. We help them process the trauma by thinking about what actually happened, what have they been telling themselves since, what have they been telling themselves since that's really hurting them and keeping them in their PTSD. And then we teach them to challenge those very extreme, unhelpful thoughts. Both PE and CPT, both of these two therapies I've talked about so far, are about 12 meetings with a therapist. And sometimes they happen weekly. We have a lot of evidence now that they can happen as often as daily, and the treatment still works well. And people, you know, show a great deal of improvement. EMDR, people talk, what's different about EMDR from other therapies is it also tries to engage the brain in these slightly different ways. So along with talking about the trauma, people do something like follow the therapist's finger or do tapping. And the theory of the therapy is that this somehow, you know, engages other parts of the brain and kind of lets things loose in a way that's helpful. And so in this therapy, the person actually can think about the trauma. They don't even have to talk about it out loud. And while they're focusing on this other movement or tapping as well. And as that happens, they're telling the negative story of the trauma and the outcome over and over. And after a while, they're able to start putting in some more positive, different kinds of things, and they feel a great deal of relief. How EMDR works is a little bit more of a mystery, but the research shows over and over again that it is an effective treatment and patients tend to really like it. Written exposure therapy is the shorter, newer one. And what happens is someone comes in and even though they're with their therapist, they write about their trauma. And at the end of writing, the therapist reads it and they talk about it, but not for very long. So this is a much shorter treatment. It's only about 5 weeks. And a lot of it is not actually even talking to the therapist, it's writing and then doing some talking with the therapist. But we've now seen several studies where people did as well as they did in prolonged exposure, as well as they did in cognitive processing. There's no homework, there's fewer meetings. So there's a lot of excitement about written exposure therapy right now. So it's, again, it starts with education with the therapist about what's happening, why we treat PTSD in this way, the actual writing and then the processing the writing with the therapist. So what makes these therapies so good? One is a lot of people lose their diagnosis, and even those who don't feel a great deal better. The other thing about it is they have a great deal of staying power. So in this slide, you see prolonged exposure therapy on top, cognitive processing therapy on the bottom. You see what people's PTSD symptoms look like before therapy with the red bars, over 70, this version of the clinician administered PTSD scale. This is from the DSM-4, it's a little older, but over 70 was very high PTSD. People came in with very high PTSD. After treatment, 9 months later, they cut their symptoms in half. Many didn't have PTSD anymore. We reached out to those same people 5 to 10 years later, and their symptoms were really even lower, considerably lower. So what's powerful about these treatments is they don't just work while you're meeting with the therapist, they actually lead to long-term sustained recovery. And we've even seen people who do much better and then something else happens, they go through another trauma, and of course immediately they feel worse, but it doesn't last long. They feel better more quickly than people who haven't been through treatment. One of the questions we often get is, what about group treatment? Because if I could put 12 people in a room together, I could treat a lot more people than I have to see everyone one at a time. And all the therapies I've talked about so far are one-on-one with the therapist and the patient. So what we know about groups is they're not as effective as the therapies I just talked to you about, but that there are some groups like cognitive processing therapy that can be done in a group, and something called present-centered therapy, where people do get somewhat better, but they're not quite as effective as the one-on-one therapies. But if this is all you can offer, if you could do cognitive processing therapy in a group, do it in a group. Better than nothing, but not quite as good as the one-on-one. Let's talk a little bit about medications. So the medications that have evidence to treat PTSD are generally similar or the same as the ones with evidence to treat depression. So we have the selective serotonin reuptake inhibitors, so paroxetine, sertraline, fluoxetine, and we have SNRIs, a similar but different class of drugs, and venlafaxine is one in particular that has been shown to work well for PTSD. So these are the first line medications for PTSD. There's others that have been studied, some of which can be maybe a little bit helpful, like nifazodone, imipramine. The evidence is very weak for those, but there's some evidence. And then there's many that actually we recommend against prescribing for PTSD. So for example, antipsychotics have not been shown to be helpful in trials, and the side effects are such that people gain, a lot of weight to the point that it really can affect their health. There's other very severe side effects, so we don't recommend those. Benzodiazepines, similarly, people can become addicted, they can habituate and need more and more. It increases their likelihood of falls and confusion, and the studies do not show it to be an effective treatment for PTSD. So really for long-term PTSD, it's those 4 in yellow that have the strongest evidence. I already spoke about benzodiazepines, but this is one of the few. The issue with benzodiazepines, at least in the US, was that before we had better information, they were very widely prescribed for PTSD. So what happened was there were a lot of people who were addicted, had habituated to them, did not want to go off them. They were having, terrible side effects and addiction issues, and yet, they weren't actually even treating their PTSD well. So we had to do a lot of work in our veterans system, for example, to actually de-implement benzodiazepines. And so now, about 10, 15 years into this effort, there's very few people who come to our veterans hospitals who are on these. But I would say just don't even go there because they create problems and they don't work well. The other question that I really wanted to cover in terms of treatment is, one of the things I hear a lot is, that's nice that you have your research, but my patients are much more complicated. My patients have many traumas. My patients have been through war. My patients have been through horrific sexual assaults. My patients also have addiction or psychosis or this or that. So I can't ask them to think about their trauma. They can't handle it. And I hear this a lot in the field, in various kinds of treatment programs, clinics, in the community, and in hospitals. It's not uncommon to hear that, but it's very inaccurate. The research does not support this. The research for the treatments I've shown you has been done with all of this population. I'm both a clinician, an administrator, and a researcher, and the trials I have run are treating people with PTSD and addiction. And I know that there's a great deal of interest in addiction in this audience. I'd be happy to do a whole talk literally on PTSD and addiction. But the bottom line of it is that we don't want to withhold those treatments from people who struggle with addictions as well. We want to treat both. So for example, in my studies and the studies that my colleagues who also do research in this area, what we see is if we treat the PTSD with the best treatments available and we treat their addiction with medication, with groups, that this is their best pathway forward. And in fact, if we don't treat the PTSD because we say they're not ready, they'll relapse, they'll do worse, and we ignore the PTSD, they're more likely to relapse and they're less likely to benefit from addictions treatment. So this is really important. And this is true with many common comorbidities. So for example, bipolar disorder, other things, we have protocols to treat them concurrently. And again, over and over, we see with different disorders that if you ignore the PTSD, it's harder to treat this other disorder. That may seem more prevalent, more of the bigger problem, but that ignored PTSD can really get in the way. Another thing we're very interested in is insomnia, because insomnia is very, very highly comorbid with PTSD. And a lot of times when someone's PTSD gets better, their sleep problems haven't gotten better, because even though the trauma might have started the sleep problems, insomnia kind of becomes its own disorder. So just treating the PTSD no longer gets rid of it. You also need to treat the insomnia. And so we have cognitive behavioral therapy for insomnia, because most medications only work for a while, or you need more over time, or they're not recommended for long-term use. But this cognitive behavioral therapy for insomnia, it's a bit of a tough therapy. People have to restrict their sleep to just 6 hours for a little while to reconsolidate their sleep. But if they can get through it, it's very effective. So I want to show you some materials from the National Center for PTSD and from other organizations that you may find helpful in your work with people with PTSD. I'll show you some resources for health professionals like you, and some for trauma survivors, for veterans, for family members of trauma survivors. So for professionals, the Medical University of South Carolina does have web-based courses in prolonged exposure therapy and cognitive processing therapy. These aren't recommended to replace in-person training with a trainer, but if it's very hard to get in-person training, this is a great start. These are about 6 to 8 hours each. If you're somewhere where you can get continuing education units, you can get continuing education for your time, and you could learn a lot more about prolonged exposure with PE Web or cognitive processing therapy with CPT Web. There's also newsletters that can be emailed to you that you sign up for, and then they just get emailed to you when they come out. So there's one for clinicians that gives you all the new information about trauma, all the latest research is summarized for you. There's one for people with PTSD that tells them what's new and gives them recommendations for new things to try, apps, things like that. And there's the Research Quarterly, which summarizes different areas of important PTSD research. So you'll have these slides and you can sign up for these if you're interested in getting them. There's also these toolkits that are basically one-stop web pages where you can get a lot of resources. So if you want to treat PTSD and in the community, or self-care information, or for clergy who are interested in PTSD, for police officers, for people who work on college campuses, you go to these web pages and they're just one-stop shops, and you can get a lot of helpful information. And I talked about the importance of assessment. I didn't go into specifically how to assess PTSD, but there's measures that are interviews, like the clinician administered PTSD scale. There's self-reported scales, like the PTSD checklist for DSM-5, where people just fill out a questionnaire about each symptom and how much they have it, how much it bothers them. We do have Ukrainian translations for at least some of these. So if you email me or the National Center for PTSD, we can get you those. And that's just an important way to ensure, yes, someone actually has PTSD, so we should actually treat PTSD. And you might find out they don't. You might find out, nope, treating them for depression or something else would be better. We also have manuals. We've shared these with you before in terms of psychological first aid and skills for psychological recovery, which we've discussed over the last few webinars. We have those manuals available. I believe these are also being translated into Ukrainian. And then we have some resources for the general public. So these are in English, but these are videos of different US veterans talking about what it's like to have PTSD, what the worst of it was for them, maybe why they didn't want to get treatment at first, but then why they did. So it can be helpful for people who are trying to figure out what PTSD is and do I have it and should I get treatment, to hear some of these stories. We also have these very short videos. They're about 3 minutes each, talking about what is PTSD. Again, these are in English. We should look into translating them. And if anybody wants to work with us on that, let me know. And there's also quite a few mobile apps. And I do believe some of these have been translated into Ukrainian, at least one that we've shared with you in other talks. But these are often, these won't cure PTSD, but they'll help people manage their symptoms, like Ptsd Coach and Mindfulness Coach can help people just, get through kind of bad times with their symptoms. There's also Ptsd Coach Online, which is for a website instead of an app for a phone. And there's trainings for families, and those are just a few examples. But you can visit the National Center for PTSD website to learn more. You're also welcome to get in touch with me directly, and I'm happy to get you over to any of these resources or talk with you more about any of the information that I shared today. I'm going to stop sharing now, and I'm happy to have any discussion that you all would like.
Thank you, Sonya. Do we have questions? Because I don't see anything in the chat.
Not currently.
No
Let
questions?
me actually,
Just
I'm just going to add my email here as well, since I did offer to answer questions. So I'm going to put it on the slide to answer questions or share resources later. And then I'll share that again for one moment.
There is a comment from Kenya for you, Sonya. Thank you so much for this very informative presentation. I really wish I work with you to enhance my career growth. Well,
thank you.
My friend from Kenya, many people would love to work with Dr. Norman. But the truth is, I've been to your country, and you have quite a few good professionals there.
And it's hard sometimes to talk about these resources, knowing that not everyone has access to these trainings, to these therapies. One of my professional goals is to make these as widely available as possible. I know we're looking into making some of these treatments more available in Ukraine. So I understand that it could be hard to see some of this and know that it's not readily available in your country, but there are people working on that. And if you get in touch with me, I can certainly do what I can to put you in touch with those people.
Sonya, there is a question. How about treatment for substance abuse with PTSD?
Yeah, I mean, that's kind of been the really one of my largest areas of research. It's so common for people to have both. And so the first thing I would say is that if you're working with traumatized people, ask them about their substance use. And if you're working with people with substance use, ask them about their trauma history and PTSD symptoms. And in a lot of settings, we've seen that upwards of 40–50% of people have both. So it is really important to ask about, and especially, if you're coming from a substance use treating place, we do know that if you don't address the PTSD. I mean, study after study after study just shows us that people relapse more, they use substances more, the substance use treatment isn't as effective. So there really is a lot of reason to treat the PTSD if you're able to. And, you know, early on, when we didn't know as much about how to treat them both together, there was this very strong belief that you can't ask someone who's still using or recently abstinent to talk about their trauma, to do these trauma-focused therapies. They would relapse, they would become suicidal, their symptoms would get worse, they'd use more. It's just not true. I have in my research and in my clinics, we've treated thousands of people with both. There are occasional symptom flare-ups or use flare-ups, and we deal with those when they come up, but I would say it's probably less than 5% of the time, much less. In most cases, we've successfully been able to treat both. We do ask people not to use before or right after their PTSD therapy. We ask them not to use if they're doing homework, like the in vivo homework and prolonged exposure, where they go out and go to a crowded store, or like, you know, if you're on something, you're not going to learn the same way that, you know, it's not going to have the same effect as if you're really sober and abstinent. And people don't have to be abstinent as long as they're in treatment for substance use, as long as they want to cut down, as long as they're willing to be honest and work with us, as honest as, you know, mostly honest even, we can do this. So in my research, again, we use a harm reduction model. As long as people have goals to cut down, we'll take them. Some people really need to go through, people with very, very heavy alcohol use might need detox first. We found that to be a very small percent of the people who come to us. Most can do it.
There is a question, any word on somatic therapy with PTSD treatment and training on it?
So there's somatic therapy. I've heard of it. I don't believe well, I know because I'm on the guideline committees that review these things. The evidence isn't quite at the point yet where we can confidently say this is an effective therapy. That's not to say there hasn't been any research, but it is to say we haven't had the large, high quality studies that will confidently let us say, let's roll this out. Let's make it available to everyone. Let's do training in this. So if you look at all the different guidelines I mentioned from all over the world, none of them have a high recommendation for somatic therapy because we just don't know yet. So in cases like that, what I say is we're not done. There's a lot of treatments out there that will be very effective that we just don't have the evidence yet. Do the good studies. Let's find out. So that's kind of where we are with somatic therapy.
The next question is, the way I read it, why benzodiazepines are not allowed since they're really nice medications and accessible?
Yeah, it's a great question. I think they can work well in the short term for certain things. So for example, for detoxing someone, sometimes they're used with panic disorder or certain anxiety disorders where someone really needs something just once in a while, acutely. It can be helpful. For PTSD, the symptoms are fairly consistent within, sometimes, you know, they get even worse. So someone really needs to be taking something over time consistently, and benzodiazepines under those conditions, what we found through, you know, about 30 years of watching people is that they're not particularly effective. Like research studies have not shown them to actually improve symptoms all that much, but people do habituate to them. They do need higher and higher doses. They become physiologically dependent. They do, especially in older adults, we see more falls, more confusion. We see withdrawal if people try to stop taking them. So the harms outweigh the benefits is basically why.
Is it possible for someone who recovered from PTSD to experience a relapse?
Yeah, absolutely. Sometimes that happens because they experience another trauma. So, you know, they get assaulted again, or something happens in their family, someone dies or something, and so they really experience a relapse. Other times, maybe they're just under a lot of stress. What we found is usually if people have responded well to treatment, we always leave the door open. We say, you know, you're doing great. You don't need to come see me every week. We did this treatment, but my door is always open. If you need another episode of care, if life throws something at you and you feel a flare up of symptoms, come back. And what we find is that if people do that, they often don't need very much. They need maybe a couple of sessions. They need some support. But if they've responded to treatment before, generally we can help them get back there.
Any special training specifically for EMDR before therapists can use it?
Yeah, EMDR, there's actually an international company called Emdr, and they run all the trainings. They have a pretty tight grip on the trainings, and they do have different levels of certifications, and they do suggest people go through their trainings. And I believe they're available all over the world. I don't know what's available in Ukraine right now. I'm sure there's places where it's not available. But if you're interested, I would look up that Emdr website. It's EMDRIA.
Mm-hmm. Okay. Thank you for a very helpful talk. Can you give us more information on the foundations of eye movement therapy? And this is the question from a person whose name I know, if this is the same person, Maria Elena Medina Mora, professor of psychiatry in Mexico, if this is the same person.
I don't know that I have too much more to say, but I would absolutely look at the Emdr website. It's very thorough. It could tell you where trainings are available. It could tell you about a lot of resources on EMDR, a lot of research, a lot of great information. Also, for the National Center for PTSD website, my colleagues and I wrote a page on EMDR that summarizes what it is, what each session looks like, what the research around it looks like, who it's been studied with, you know, what we know. So that's just about a page and a half that you could go read if you, I would just put into Google EMDR National Center for PTSD or Sonya Norman, because I was an author on it, and it'll come up, and that's just a good summary of EMDR. But if you want to learn about Emdr, I would just go to the website. There's so much there. It's such a rich resource.
Can we combine different modalities you just discussed, or one modality at a time to treat PTSD?
Yeah, that's a great question. And there's been some studies to look at that. And you would think that more is better. But in fact, sometimes when we do a little PE and bring in a little CPT, it's not as effective. So we generally recommend doing the treatments per protocol. If someone doesn't respond to one, try the other one. So I wouldn't blend PTSD treatments if you don't need to, but what we can blend is treatments for people who have comorbidities. So let's say someone has PTSD and an opioid addiction or an alcohol addiction. We could treat them both concurrently, so they can come to me for their PTSD treatment and they can go to a clinic where they do groups and other things for their addiction. Or we could treat them in an integrated fashion. So there's actually a protocol called COPE, which is PE and relapse prevention for substance use. So it's prolonged exposure for PTSD and relapse prevention for substance use, and it's in one session. And people just have to come once a week and they get treatment for both. You know, usually if someone needs their treatment every day or, you know, residential treatment, this might not be the one for them. But for many people who are working and busy and have childcare, that they do great, and it helps them actually achieve treatment by doing, you know, coming once instead of coming multiple times to see me for PTSD and someone else for their alcohol use. So there are protocols like that.
Here's a great question, I guess, from a colleague from Nigeria. How does culture affect those therapies? Which treatment is likely effective across cultures?
Yeah, you know, we're still doing a lot of studies on that. I do have a colleague who from Stanford University who's gone to some African countries and done cognitive processing therapy and trained local lay professionals, you know, not people with PhDs, just people in the community to do the therapies, and she's had very good effects. If you want to email me, I'm happy to put you in touch with her or share her articles with you. So we don't know enough yet. And I do think that there's probably some elements of these therapies that may not sit well with certain cultures. And I think understanding how trauma is understood in different cultures is very important. So for example, one of my colleagues did some work with people from Cambodia, and their understanding of what happens in the body after trauma is really, was so pivotal to their understanding of PTSD, and just had to be incorporated into treatment. We couldn't not address it, with these treatments as is. So it's a very important question. We have a lot more work to do there.
Here is one more question. How long medications are required, although the source of trauma is always remain for long? That's
yeah. So it's a great question, because with the therapies, they seem, these trauma-focused therapies, at least, they seem to be, they seem to continue to work even after they're done. With the medications, the expectation is more that they work while the person is on them. So there isn't necessarily an expectation that when someone goes off, that they'll continue to see those benefits. Sometimes people do, though. Sometimes just getting them on the medication so they're able to get that job they want, they're able to get into a healthy relationship, they're able to get their energy back and start enjoying things again. Then you can gradually try taking them off the medication after a few months, and it's possible that having put all this other stuff into their life, the benefit continues. But you have to monitor it carefully because it's not guaranteed.
Let's do one more. Does this psychological therapy offer same benefit to secondary survivors of trauma with PTSD?
That's a great question. I think this is where assessment is very important. So, for example, if someone is in an explosion and thinks they may die, they may develop PTSD, right? But their husband or wife, similarly, their loved one was just in an explosion and they thought they might die. So that person also had a traumatic event and also certainly could develop PTSD. That person absolutely had that same traumatic event. And so if they develop PTSD, those same treatments would be the ones to try. But it could be other things. Maybe the person's just very, very depressed because they've been caring for so long for someone with PTSD who's irritable and never wants to leave the house, and they don't do the things they used to do together anymore. And so then you would want to treat the depression, right? Or maybe it's a healthcare provider who hears about a certain trauma and becomes very upset and has a hard time putting it out of their mind and has sort of that kind of secondary experience. Again, there's ways to address that are a little bit different than PTSD treatment. So I think if you're feeling that, if you're seeing it in someone, that assessment is really important. And if it is PTSD, treat it, but it may well be burnout or depression or something else.
Okay, Sonya, there are lots of thank yous and lots of positive comments. Thank you everybody who wrote a comment for the webinar, for this one and the previous ones. Sonya, thank you from myself for your time and effort. Thank you. It's really, really greatly appreciated by everybody, certainly by me. I just want to remind again all of you who participated in this series of webinars, there will be a series of consultations. Definitely our focus at this point, for obvious reasons, is the situation in Ukraine and building competencies and competent workforce, competent to address various aspects of war-related trauma in Ukraine. Although people from other countries, you will definitely be welcome to join those clinical consultations. The chances are you might see similar clinical situations, and many of the skills that we've been talking about are actually applicable across the board. It's just right now the necessity is in Ukraine because of the situation there. Thank you all. Take good care of yourself. Take good care of each other, and we will be seeing each other again very, very soon. You will be getting emails with the dates and times and other logistical information about the consultations. And in the meantime, thank you and good luck to all of you. Sonya, thank you again. Olivia, thank you for your support.
Thank you, everyone. Thank you, Igor and Olivia.